This conference will now be recorded.
If you want to get started.
All right, guys, so welcome to Journal Club. It's going to be a little bit different today. We're only going over one article, and then we'll be going over some cases, 3 of them. So first off, with Journal Club, this is the article that was sent out. It's use of helmet-based non-invasive ventilation in air medical transport of COVID-19 patients. It was published in Air Medical Journal this year. It's authored by Robert Beckel, who is a clinical educator at LifeLink 3. It's a helicopter fixed wing air medical transport company based out of Minnesota and Wisconsin. This guy's also a registered nurse and also a flight paramedic. So the article itself kind of starts off with a job. An air medical transport helicopter requested for interfacility transport from a small rural emergency department to a tertiary center. The patient, hold on, I can't even see my screen, is a 60-year-old male with rapid shortness of breath and weakness. He's been experiencing fever for approximately a week and had a positive COVID nasal swab test. In the ER, the patient was placed on BiPAP because of his severe hypoxemia and respiratory distress with little improvement. So they basically called you because the patient had to be transferred to a tertiary care center. When you arrive, the patient is in an upright position. He's alert. He's tolerating the BiPAP well. He has a dusky cyanotic appearance with cyanotic extremities and labor respirations at a rate around 24 to 28. His saturations are the mid 80s, and the rest of the vitals are normal. So you know this guy has to be transported. You're by air. The question really is, do you keep him on the BiPAP? Do you intubate him? Are there alternative ways to transport him? But keeping in mind that you have to be concerned about your own safety as well. The intubating a patient would be the most definitive process or airway, and it would be the least risky for the air crew when his airway is secure. On the mask, it's you can get leaks around the mask itself, and that could be, of course, a threat to you as a crew member in a closed environment like the helicopter. So they decided that this patient would be a good candidate for a helmet, non-invasive airway. He didn't have really any contraindications. So what the crew did was they explained the therapy to the patient. They provided him with some hearing protection. They applied the helmet to his head. Initially, it was actually a bad seal, but they had to redo everything. And then the second time they attempted, it was a tight neck seal. And they put him on the high flow mode on a vent at 60 liters with FiO2 100%. During this process, they were trying to get him more accustomed to the actual helmet. They gave him some Versed for his anxiety, especially with the helmet around his head. You can imagine he was probably a little claustrophobic. After the helmet was applied, it seems like his vitals improved. His saturations were in the mid 90s. His respiratory effort decreased. The next part of this was the crew had to calculate the anticipated flight time, the amount of time that it would take for him to be transported to the helicopter, the ride itself on the helicopter, and then from the helicopter to the hospital. This all had to be calculated, especially with the given with a set amount of oxygen on board on the helicopter. During this time, they also had to make sure, while in the hospital, that the patient was okay with the helmet, that he wasn't deteriorating, because then, it's always better to adjust and change things while on the ground than in the air. So this patient ends up doing pretty well. He gets transported to a tertiary center. He's transitioned to high flow. They don't really note his outcome, whether he ends up getting intubated, whether he walks out of the hospital, that kind of stuff. But overall, this mission was a success. So we know that COVID patients that require airway support have the best outcomes when we avoid intubation. In the hospital, we've been using high flow, nasal cannula, CPAP, BiPAP. We haven't really used helmets, at least where we've worked. The helmet itself is a sealed, confined space, which can isolate droplets and aerosols, reducing exposure to providers, right? And some studies have shown that the helmet non-invasive airway is a viable, sometimes superior alternative. So good candidates, patients with hypoxemia with mild, moderate respiratory distress. They have a requirement of 6 liters or greater. It can be used in place for high flow nasal cannula or CPAP or BiPAP. Some of the contraindications would be somebody who's in respiratory failure, somebody who needs an immediate intubation airway, they're altered, they're vomiting, they have a decreased level of consciousness, they're agitated, secretions that aren't able to be cleared, someone who's really claustrophobic and they're not really doing well despite giving them adjuncts for their anxiety. They also talk about whether it's really practical, especially in the helicopter. You have a limited amount of cabin space, the ceiling height, depending on what kind of helicopter you're flying, sometimes it can be difficult to place a person and their head in that limited space. If you're going by ground, maybe this isn't as big of an issue, but there are other issues with transporting by ground, right? Other problems would be, you have a high flow oxygen device that's capable of some leak, or does the ventilator allow for leak? Oxygen flow and availability is another problem, and then also fitment, right? But that really shouldn't be a problem so long as you're putting it on correctly. So they mentioned 2 settings. They kind of go over what they've been using. There's 2 settings that they've been using. One is the non-invasive vent settings, and one is through high flow. And they mentioned that the flow generated by their high flow generator has to be at least 60 liters. You need to be able to titrate their FiO2. And some of the other papers I've read using these helmets, some of the flows were as high as like 100, 120, which is a lot more than they had mentioned. Really, the high flow is needed to allow adequate CO2 washout. Remember that the helmet itself is anywhere from 10 to 15 liters. You add in the person's lungs, that could be anywhere from 200 to 1 liter. So really, you have to have a flow that's able to kind of push that oxygen all the way down to lungs, and that's a lot of volume. That's almost 12 to 15 liters of volume. And if you don't wash that out, you have CO2 retention in the mask, or sorry, in the helmet, and that can actually lead to CO2 narcosis, confusion, and basically like an intoxicated appearance. There's 2 ports to the helmet. One is the inflow. It's either from the high flow generator or ventilator, and then the second port can go back to the ventilator, or it can just be a viral filter with a PEEP valve. At least this is how they were using it. The non-invasive modes, pretty much what you would expect from any kind of vent on CPAP or BiPAP. And on the right side, there's just a picture of their setup. Although if you look at other people using this device for airway support, they've had this set up different ways. Usually this is the second port on the right is actually connected back to the vent, so they can measure the inspiratory and expiratory volumes to make sure there's basically no leak. The biggest concern, of course, with transport for someone who needs oxygen support for airway support is really the amount of oxygen you can carry. And they mentioned that this is kind of a limitation of the helmet itself. Prior to transport, the patient's FiO2 requirements, their flow requirements all have to be considered because you are only using a limited, or you're only carrying a limited amount of oxygen on your vehicle, whether it's a helicopter or a truck on the ground. These always have to be considered. There's usually, we mentioned it before, but there usually has to be sufficient oxygen on board for the person plus a reserve, because at any time the requirements might increase and you have to be able to calculate that and adjust for that. Next, they go on to like an oxygen duration table that they use to basically calculate the amount of time they have for transport, given amount of PSI or pressure in their oxygen tanks. And they have a little formula that they kind of put on their article for them to use when they actually have patients that are transporting. So they've done, in this article, they write that they've had 10 successful interfacility transports and 1 on-scene response. Of the 10, 5 patients were confirmed COVID patients, 3 were suspected, and then 2 were low risk. All these patients were transported without any complication. None of them deteriorated or required intubation during transport. No cases of neck seal failing in any of their cases. However, in this case, as well as another case, they had to actually adjust the seal. So they had to basically put the seal on twice because the first one didn't work. So just a video on how this is applied. This is obviously an older video. And you can tell because people are not wearing PPE when they're applying this to the patient. Oops, sorry.
The helmet interface for delivery of non-invasive ventilation is a transparent hood that covers the entire head of the patient. A soft rubber collar seals the hood at the neck. First, measure the neck size of the patient. Using the collar size guide, determine where to cut the rubber collar to ensure a tight and comfortable seal at the neck. Attach the rubber collar to the plastic inner ring of the helmet. Now attach the inner ring to the helmet's transparent hood and ensure a tight seal. Attach the ventilator's inspiratory and expiratory tubing to the port sites on the helmet. Set the ventilator to pressure support mode. To improve patient ventilator synchrony, adjust the rise time to 50 milliseconds and change the end flow to 50%. Stretch the rubber collar of the helmet and place over the patient's head. Once the helmet is fully inflated, attach felt arm straps to the front and back of the helmet. This secures the helmet's position on the patient's head. The helmet pressurizes in seconds. Heat is increased to achieve adequate lung recruitment and oxygen saturation. Notice that at this level of heat, there is no detectable leak in the ventilator circuit. FiO2 is also titrated to a non-toxic level to achieve oxygen saturation above 90%.
All right. So there aren't a lot of studies on at least transport patients with helmets. This is kind of one of few, I guess it's not even a study, it's just a case article. But there's actually a study in 2016 University of Chicago, single center RCT, 2012 to 2015, about 83 patients with ARDS requiring non-invasive ventilation through a face mask. They were randomly assigned to either the helmet group or just the face mask group. And they actually saw some pretty good outcomes with a helmet. Their primary outcomes were the proportion of patients requiring intubation. Secondary outcomes included 28-day invasive ventilator-free days, duration of ICU stay and hospital length stay. The 44 patients in the helmet group, there's 44 patients in the helmet group and 39 in the face mask group. The intubation rate of the face mask group was 61%, so very high. And then the helmet group was only 18%, and the number of ventilator-free days was much higher in the face mask. In the helmet group, 28 versus 12.5 days. Mortality was also lower in the helmet group, 34%, so 15 patients versus 22 patients, or 56% in the face mask group. And this doesn't really cover, transport as a whole, but I think it does kind of show that for some ARDS patients, this mode of ventilator support might actually be better than the face mask. There's another study that was actually recent from Milan on COVID, and it's not really a comparison. There's no comparison. It's just they're looking at patients who had the helmet on and the outcomes. And oddly enough, there was actually a high percentage of patients that end up dying and being intubated. 44% of a group of 157 patients ended up not doing so well. 21% were intubated, and then another 23% died because they were DNR, DNI. But like I said, there aren't a lot of articles on the helmets being used for transportation, but I think it's something that could be used. The biggest limitation, I think, would be the size of your vehicle, whether it's a truck or a helicopter, as well as your oxygen carrying capacity in that vehicle, because that's probably the biggest limitation. When you think about how much oxygen you're actually using on a regular patient in the hospital, that high flow can go anywhere from 10, 20, 30 liters at a max of like 60 liters, but majority of people are at 40 liters. Now with the helmet on, that helmet itself is about 10 to 15 liters. Adding that to your lung volume itself, that's a lot of volume, right? So you're gonna run out of oxygen pretty fast. And that's kind of my biggest concern, because wherever you are, whether you're in the helicopter or in a truck, you're not going to be carrying as much as somebody not in the ER, or in the ICU or hospital, or in general. So that would be the kind of the biggest limitation, just your ability to carry oxygen and how fast you're going to use it on a patient who's hypoxemic. With that being said, I'll open up the floor to you guys as far as your thoughts on using this in the future, if it's ever available in our system, or even pre-hospital or hospital side. Would you guys want to use this?
I would want to see it in person and see what the
Brian, can you
patients
hear me?
actually
It's Matt. Anybody hear me or no?
Yeah, we hear
great.
it.
Yeah, okay. So were you able to find any more on when these helmet CPAPs were used, or helmet BiPAPs were used in Italy? Italy reported a really high incidence of pneumothorax, and there was a thought that it was possibly related to the helmet CPAP, and I don't know if anybody's ever really figured that out. Did you run across any of that when you were looking at this?
No, I didn't really see a lot of complication on this. And I'm not sure if that pneumothorax was secondary just to, COVID or the population, because a lot of these patients, a lot of these patients have really bad lung disease, and there's going to be a lot of scarring. They're going to be prone to pneumothoraxes, but I don't know if it's going to be secondary to the helmet. The helmet, it seems like they're using at least a PEEP of 10, which sounds like a lot, but realistically, it's a PEEP of 10 is really to keep that mask inflated and to prevent leak. So I don't think it's even that high enough to actually cause a pneumo. So I'm not really sure on that, Matt.
Yeah. Okay. I could see the flow issues being, I don't know that, I still haven't seen a device that really delivers true high flow. The Hamilton T1 Bud Lavin was talking about comes close, but short of taking the hospital devices into the ambulance, I haven't really seen 60, 70 liters a minute of flow delivered. It continues to be an issue. And then the whole source, I mean, you can do a couple of E-tanks, that kind of thing, but yeah. Some helicopter systems, and they didn't say whether they used it or not, but liquid oxygen systems are pretty common on helicopters as an airframe device, but only in the medical interior aircraft, which I assume that they're using.
Yeah. All right. Anybody else? Okay. So we're going to switch over to some cases. All right. So these are some cases that we've collected over the last couple months. Some of them are mine. There's actually 3 cases. One of them is somebody else's. So we start off with this case, and if you're on video, it's probably easier because there is a lot of video stuff. If you're not on video or you can't see videos, it makes this a little bit more difficult. So the first case is going to be a 17-year-old with chief complaint cough. If you're a medic, if you're a paramedic, if you're a physician, medical student, I would consider these cases in your own kind of world and think about what you would do or what you would want to do as far as your workup. So this 17-year-old female, she's coming in with a cough. She's had a cough for about 2 days now. It's not productive, but it's constant, and she has these coughing fits, which makes her sides hurt. She's not short of breath. She has no fevers, no runny nose, no sore throat, no sick contacts, no travel, no known COVID contacts. As far as medical history goes, she denies anything, no allergies. She's not on any medications, but she does smoke marijuana, and she has no other toxic habits. Anything else you guys want to know?
She vaccinated?
Yes, born in this country.
All right. She vape with the marijuana?
Maybe. Wasn't sure.
Any history of asthma when she was younger? She doesn't remember.
No history of asthma. All right, moving on. Her exam, we'll go through the vitals first. She's AFib 98, heart rate 134, so she's tachycardic. Respiratory rate 17, so normal. Blood pressure is fine, 112/59. Saturation is 93% on room air, and then she kind of desats to low 90s when she walks around. She's 38 kilos, so very small for a 17-year-old. On exam, she's awake and alert. Not really much in respiratory distress. She is coughing intermittently though. Her skin is warm and dry. Oral mucosa is moist. She has no stridor. Going down to the chest, she's wheezing bilaterally, but she's not tachypnic. She has no rales or rhonchi. She's moving good air. She's tachycardic, but no murmurs. Going down to the extremities, she has no pedal edema. She has no leg swelling. Anything else you guys want to know that's not on there?
More from the history. Is she any recent travel, family history, like PEs or heart problems or anything?
Nope. Yes, no family history for anything. No one's sick at home. She doesn't go to school because COVID kind of shut everything down. But yeah, pretty much no family history.
Any
Is her
like
cough productive?
It's not productive. It's like a dry cough.
Okay.
Emerson, anything else?
no? I'm assuming she's been at home, so no.
Yeah. All right. So we talked about more questions. So differentials, COVID is probably the most important ones. Even though she is at home, people are still getting, COVID. What would you guys want to do off the bat?
Position seems clear. She's likely going to get admitted if she's 93 on room air and probably desaturates when she walks. So probably the COVID labs, including a dimer and procalcitonin. Consider therapeutic Lovenox and consider antibiotics if the procalcitonin is elevated. And then I don't send all these people for PE studies because they're prone to PE. So I usually just treat them with therapeutic Lovenox if the D dimer is high. I don't know how everyone else approaches it.
I will say, I don't know if anybody listened to MRAP. I think it was this month. They did cover, or EMA, sorry, for last month, did cover a couple studies and showed that they're not really convinced that COVID actually does increase your risk of PEs and DVTs. So just keep that in mind, that maybe have a lower threshold to go for a PE study. But for this patient specifically, I would at least do a rapid COVID, and if it's negative, I would send her for a PE study.
Interesting. So, I mean, she is wheezing, she's tachycardic. This is what was done initially. So she got fluids, nearly 40 cc's per kg. Remember, she's only like 37. She's on 2 liters of nasal cannula. She gets a neb. No solunitral is given initially, no steroids are given initially because she doesn't really have a history of asthma, and then she gets like a lidocaine neb for coughing. After the treatments, this is the initial diagnostics. For EKG, for those of you who can't see, looks like it's sinus tach at 140, 150. The axis is normal. There's no ST elevations. Doesn't look like a prolonged QT or anything. No T-wave inversions. Pretty much a normal EKG. For X-ray, looks a little bit hyperinflated. Otherwise, there's no obvious infiltrate. No real effusions. Pretty much looks normal to me. So going on to her labs. So she does have a white count at 21. Some bands at 7. What's interesting with her is her eosinophils are really high. They're actually 24%. And absolute eosinophils are actually really high as well. It's 5.1. And if you thought this is COVID generally doesn't have eosinophilia. If anything, it would be low. Her hemoglobin's pretty high for a female that I would presume is menstruating. Her creat is also 0.8. For someone who's 37 kilos, that's AKI. The rest of her labs are pretty much fine. And remember, like with eosinophilia, you're thinking about like allergic reaction, parasitic infection, sometimes cancer, that kind of stuff, which is kind of odd if you thought it was, again, COVID. So after your fluids, she is still tachycardic at 120, 130. You've done that so far. What else would you guys want to order, or would you just send this patient home? What do you think?
I think we should get that CTA, evaluating
Yeah.
the lungs further.
And a thyroid study.
Yep.
Yeah. So two things were actually done. One was the echo, and just to make sure there was no pericardial effusion that you were missing, and it was pretty much negative. Heart looked hyperdynamic. The RV looked okay, and the IVC, although not shown, was collapsible. Going down to her PE study. Hold on.
Is there
So if
free
you're
air?
looking at it,
A lot of crap in there.
yeah, so there's no PE or dissection. It's obviously hard to see when you're looking at it from a computer, but there are some bilateral patchy ground glass opacities. There's no pleural effusion, and it seems like the aorta, sorry, the pulmonary artery looks at least as big as the aorta as per the radiologist. So they're basically calling it chronic pulmonary hypertension with maybe like a viral pneumonia, right? And so this patient is actually at a pediatric hospital. They're given a dose of solu-medrol and they're transferred to RWJ. A lot of the transfers that we've been doing, at least within our network, they get an initial rapid COVID test, and hers was actually negative. So at RWJ, her oxygen requirements goes from like 2 to 10 liters, and then she gets a second swab, which is also negative. She gets treated with antibiotics and steroids, and then she's discharged a couple days later with diagnosis of pneumonitis, and they think it was from drug use. So interestingly enough, they actually didn't think it was COVID. I actually spoke with the pulmonologist at New Brunswick, and they didn't think it was COVID at all. And like Emerson, when you mentioned about vaping, this was actually what they thought was secondary to, or they thought that was her coughing was actually secondary to that. So before all this COVID madness happened, there was a increased concern for those young 20-year-old males that were coming in with shortness of breath, dyspnea and exertion, fatigue.
This
And look
conference
at
will now be recorded.
Around the heart, it actually is a little bit more concerning for like right there. If you actually look towards the pulmonary vasculature and the heart, not right there, but if you go down a little bit further, that is consistent with vape lung, because it's got like those popcorn appearances, or free air like in the mediastinum or something.
Like right here?
Yeah.
Yeah. But I think most people would just look at this CAT scan and say, hey, it's COVID, Yeah. And that's what a lot of people would do.
Oh yeah, nowadays I probably would do the same thing.
Right. All right, let's talk about case 2. So this is an 84-year-old male with shortness of breath. Comes to the ED, complaining of shortness of breath. He's had 2 days of fever, chills, body aches, fatigue, worsening shortness of breath. He also had a dry cough over the same period. Again, no known COVID exposure, no chest pain, no recent travel, no prolonged immobility. As far as past medical problems, he has hypertension. He had some stenting after an MI. He has GERD. He had some kind of ciliotomy, and then he had a GSW to his left hand, and it's been amputated. No known allergies. Medications, he's on Lipitor, Plavix, aspirin and Allopril, Lasix, Metropol, and nitroglycerin, and no reported toxic habits. You guys want to know anything else?
You said he's coming in from home, or is he coming in from a skilled nursing facility?
Yep, he's from home.
Okay.
All right, moving down to this physical exam. So first the vitals, his temp is 98, heart rate is 127, tachycardic, respiratory rate's 26, so he's a little tachypnic, blood pressure is fine, 152/81, saturation is 47% on room air, his weight's 66 kilos. On exam, he's awake and alert, he's in pretty moderate respiratory distress. He's tachypnic. We'll go straight to the respiratory exam. He has mild retractions. He's tachypnic. He has bilateral rales, no rhonchi, no wheezing noted, and he has bilateral breath sounds. Cardiac, he's tachycardic with no murmurs. The rest exam is, I mean, he has dry oral mucosa, and then he has like a left upper extremity amputation. That's pretty much it. Otherwise, no deviation of the trachea, no stridor, no cyanosis noted, at least on this exam. All right, so what do you guys want to do next?
Is he tripoded, and do we know why he had his upper extremity removed?
It says GSW.
Okay. It's not vasculitis or
At least on the exam that was reported, he is not tripoding, but I imagine he could be.
I mean, moderate respiratory distress is enough.
Yeah.
So
is he
tubing him.
like high flow?
Yeah, so he's put on a non-rebreather, 15 liters, and that actually takes him up to 100%, but he's still tachypnic. They gave him some Tylenol for some reason. And then they note that they're holding off on fluids because his EF was 20-25%. Anything else you'd like to do?
Bedside ultrasound.
Yeah. So in the chart, it wasn't really documented that it was done. So we'll just kind of go through this really quick. That's the EKG. It looks sinus. There's some inversions in one AVL. Otherwise, nothing too crazy for me. And then this pops up, right?
He's got a couple pneumos.
Yeah, he has a pretty bad pneumo on the right side. His good lung, the left one, doesn't look too great either. There's infiltrates there. And I'm sure his elevated left hemi doesn't help him with his breathing either. There's also some densities in his face. I imagine that's from this GSW from before. But yeah, so this guy gets a pigtail, and after the pigtail gets placed, his lung is up, but you can still see a residual pneumothorax in the apex, and the lung that is up now still looks pretty terrible. They note fibrotic changes with superimposed bilateral infiltrates. So we know that COVID patients with pneumos have very poor prognosis. We'll kind of talk about that later. These are his labs. He has no white count. Some of his inflammatory markers are elevated. His ESR, his dimer, his ferritin, his CRP. His creatinine is elevated at 1.7. His protein is 10.1, so he's probably a little dehydrated. Lactic is 3.8, probably from his hypoxia. He has a trope of 0.3, a BNP of 1500, possibly all from that pneumo. And then initially his ABG shows hypercapnic respiratory failure with the CO2 elevated and his pH 7.2. I imagine he's probably a retainer, so that bicarb 26 should be probably higher if it was his baseline. So his course, so on the first day, he actually has an ICU consult for his hypercapnic respiratory failure, but they, of course, reject him. He goes to telemetry. His initial rapid was actually negative. Over the course of the second night, he actually has a rapid. I guess they took off his BiPAP while he was eating, or before he was eating, and then he became obtunded and hypotensive, probably from hypoxia, but his mental status improved. The second, I guess the third day in the morning, had another rapid, and there's a discussion with the family for intubation or another chest tube because he still had that apical pneumo, but they didn't want that and they wanted comfort care instead of aggressive measures. Third day at night, he became bradycardic and basically arrested. So this guy actually had really bad lung disease prior to COVID. If you actually look at his chart, he had pulmonary fibrosis. So I am not sure if that was his baseline or not. That's pretty bad for a baseline, but if there's superposed infiltrates, I imagine there's some kind of infectious process that made him decompensate, especially when he's complaining of cough, fever, body aches, and whatnot. Could be a pneumonia or some other viral process. Could be COVID still, despite that negative swab. So I just want to go through quickly over the ultrasound. It wasn't documented in this resuscitation, but I think it's definitely useful, especially for, if there are paramedics on this call, ultrasound is going to be something that's going to be coming soon, I'm sure, and it's something that everyone's going to be able to use as it becomes cheaper and more accessible and more portable. Very oftentimes we talk about COPD versus CHF, and we're not always sure which one it is because maybe they're wheezing, they're tachypnic, their sats are low, and the ultrasound can help distinguish between those two diagnoses. Can I just run through this because we all kind of know what this is? B lines are suggestive of basically interstitial edema. Oftentimes it's used to differentiate between CHF and COPD, but remember that there are other differentials including ARDS, pneumonia, pulmonary fibrosis. A lot of COVID patients are going to have B lines as well, and it doesn't mean that they're in failure. Absent lung flooding for pneumothorax, and then a lung point sign. As you can see, there's a transition point right around here where there's an area of lung sliding and area without. And then another, I guess, way to look for a pneumo would be just putting your ultrasound on M mode, placing it on the chest, and looking for a barcode sign, which is on the right. Versus on the left, that would be normal, right? It's just, what is it, Sandy Beach or something? Fusions. And this is kind of a quick algorithm of what to look for. Is lung sliding great? Are there B lines? Maybe it's failure or some kind of pneumonia or ARDS. And then you look for a lung point sign versus a barcode sign for a pneumothorax or absence of lung sliding. All right, any questions on that? Yeah, okay. The last case is an 8-year-old with chest pain. He's had chest pain, he says, for a couple weeks. His right side is non-radiating. It's worse with deep breaths and lying still. Oddly enough, when he's active, he says that the pain improves. Again, no fevers, no cough, no runny nose, no sick contact or travel. He has hypertension. He has CAD with stents. He has some kind of prostate cancer with radiation chemo. His daughter says he's been cancer-free for the last 20 years. His most recent PSA was this year. It was normal. He has dementia as well, so take his history for for what it is, I guess, because you're not really sure if he knows what he's talking about. Allergies, no known allergies. Medications, he's on aspirin, Plavix, torvastatin. He was a smoker for 40 years. but hasn't smoked in the last 20, no other toxic habits. Any other questions or any other things you guys want to know? All right, moving down to his physical exam. All right, vitals first. His temperature is 98, heart rate is 78, respiratory is 18, blood pressure is 155 over 98, and his SAT's 92% on room air, weight 72 kilos. So overall, his exam, he looks comfortable. There's no acute respiratory distress, not tachyptic, no accessory muscle use, no stride or anything. Body mucosa looks moist. Going down, cardiac exam is pretty much non-contributory. He's not tachycardic. There's no murmurs. No pedal edema, but he has this edema in his right upper extremity. That's probably the only odd thing. Otherwise, he's alert and orient ×3. He's moving everything. All right, so what do you guys want to do next, or what are your differentials? If your thought is COVID for this patient, he's 92%, do you want to just send him home?
Any swelling to an extremity and chest pain, I would put PE up there too.
Yeah. Oddly enough, if you actually look at his chart, he's been here before for swelling his right upper extremity. So actually might be normal for him. But yeah, let's go through some diagnostics. So his EKG, sinus rate of like 100-ish. There's some T-wave inversions in V4 through V6, or sorry, V3 through V6. Looks like a strain pattern. Here's a PVC. Otherwise, everything else looks okay. Going down to his X-ray. Looks okay to me. I mean, it looks a little bit weird, but it also looks okay. It looks pretty clear. I don't know if you guys see anything that I can't see. Going down to his labs. So he's just got some basics. He has a white count at 20 with some bands. His create's 1.5, which is elevated for him. Troponins negative. BNP's maybe slightly positive, but he doesn't look like he's overloaded on exam. So what would you guys do next? So he probably has some kind of infectious process. That's 92%. Would you just cover him with antibiotics and admit him, or would you discharge him on antibiotics? Try to, tell him to come back if he's still, if he gets worse or whatever. Or what would you guys do?
He needs a UA. He's older with a white count.
Yeah. Anything else?
A hard time sending a 90-something-year-old with a white count of 20 home.
Yeah. But his complaint's also chest pain, right? It's not really any other symptoms, really.
Sounds like an easy dispo then.
Yeah. So yeah, so he gets a PE scan, and the reasoning on the chart at least was that he has some kind of remote history of cancer that everyone says he's cured of. He has chest pain, so he's going to come in regardless because it's going to be ruled out ACS. But like you said, with the exam with a swollen upper extremity, is PE still up there? So he gets a scan, and there's several findings on there. So I'll play it twice. I'm sure some of them will be more obvious than others. All right, so it's going to stop right there, but even in the right lower lobe, you see this little triangle thing. And they're actually calling that a pulmonary infarct. I've never seen that before. So that's kind of interesting. On the left side of this this slice, there's also like a circle on the far left, or I guess the patient's, left lung. And that's actually a nodule. And if you actually look at the scan again, there are multiple nodules everywhere. Along with that, he has multiple ground glass opacities with peripheral distribution. Could be COVID. And he has multiple PEs, which are harder to see on this, but there's no strain, there's no bowing of the septum. So this guy ends up getting heparin drip. He gets some fluids, he gets antibiotics, and he gets admitted. Initial COVID screen was actually negative. He gets a pretty extensive workup for his pulmonary nodules, presumed metastasis of his prostate cancer. And he ends up developing some pleural effusions while he's in the hospital, but his saturations have been maintained on 2 liters. Still getting worked up for METs. So I guess the point of all these cases is that even though COVID is usually the leading diagnosis and it could be contributory to the patient's disease process, it's not always the reason why they're there. For the first patient, even though COVID is still a possible and likely diagnosis, maybe it's something else. For the second case, with a pneumothorax, maybe the patient had a viral process or some kind of pneumonia that caused the pneumo. But the reason why he came in wasn't so much because of the symptoms that he had, or sorry, the viral symptoms that he had, is more because he had a pneumo and a shorter breath. The third case, patient had what seems to be a pulmonary infarct, which caused his pain. And COVID could be part of the picture, but it's not always the main reason why they're there. And even though it's so prevalent now and back in April, we shouldn't always kind of lock in that diagnosis because when you do, it could eventually sink you when you anchor on that single diagnosis. All right. With that being said, we're done here. Any questions, concerns, comments?